First, before we begin, I'd like to acknowledge the Aboriginal and Torres Strait Island people, the traditional owners of this country. We pay tribute to their physical and spiritual connection to land, waters, and community, enduring now as it has been through time. We pay respect to them, their culture, and elders past, present, and emerging. I'd like to run through some housekeeping. My name is Barbara, I'm the Education Coordinator for SAPNIA. If there are any technical issues with Zoom, any link issues, please just have a look at the FAQs in the chat feature. Microphones are on mute. Submit any questions that you have through the Q&A feature. Any evaluations will be at the end of the session, so if you could just complete them. Certificates of attendance will be sent out electronically following tonight's session. I'd like to thank Adelaide PHN for financing and contributing to this education session tonight. So I'd like to introduce our presenters. Dr. Jacqueline Yu is an Australian-based health professional and trained as a GP with a special interest in paediatrics, women's health, antenatal share care, breastfeeding. She currently works part-time at the Arkabar Medical Centre and is a GP liaison for Cullen. Dr. Jessica Gillard, our endocrinologist, is a clinical pharmacologist and obstetrics physician. She undertook her specialist training in Darwin, Brisbane and Adelaide, and she has a special interest in the management of women's health during pregnancy and the impact of chronic disease and medications on unborn children. Ms. Kerry Chambers became the first pharmacist credentialed diabetes educator in Australia 10 years ago and continues to lead the evolution of diabetes care by community pharmacists in primary care, setting up a dynamic pharmacy-based service in South Australia. Kerry provides increased access to holistic diabetes care in pharmacy setting, which links to the National Diabetes Services Scheme. Thank you very much. Enjoy the session.
And there's a short silence now. This is Jackie Yo speaking while we just work out the technology and Jessica gets the slideshow going. So bear with us. In a moment, we'll shout for Mel's help.
Yeah.
Our PowerPoint, there we go. And I'm sure everybody's been experiencing all the fun of technology over the last 6 months.
This isn't my computer, so I'm not sure what I'm doing. Yeah. And then, can you share screen?
Well, while we're waiting for everybody to get started with it, Kerry, I'm actually very interested in hearing more about you being credentialed as, because you're a dual trained, aren't you? You're a pharmacist and you're a diabetes educator.
Yes.
Yes. So tell me a bit more about that.
So when you have your original discipline, and then you go on to be a diabetes educator. So they can be nurses, pharmacists, dietitians, doctors can be as well, podiatrists, and I think also now they've opened up to things like physiotherapy.
Really?
Yeah. So and that allows people to sign the NDSS forms.
Yes, those forms that we fill in when we're enrolling people and they get access to the needles and the strips and all those fun things.
Yes. And of course then you can charge Medicare and the private health insurances for education. So it allows a much more cost-effective way for people with diabetes to see allied health.
Yes. Yeah. So they'd be able to use the extended primary care items with a care plan.
Correct. Yeah. Because I think we'll perhaps touch on it a bit later, but the services through all of our hospitals now are becoming so overloaded, and we had that discussion earlier, so I might talk on that if we have time a bit later.
Yes, that's a very good point. We might, thank you for that, Kirili. We might move to Jessica now, if you're ready to get going.
Wondering, have you got the screen available to everybody?
Yes, we'll just actually come across them and then
But yes, that's a really good point about the public hospital services being very, very overloaded.
they are.
Yeah, and I certainly see that in my position as GP liaison officer. And I'd imagine you would too, Jessica. Whereas once upon a time you might have referred into a public hospital for diabetes education, I don't think I've done that for a while, because the chances are that they're probably not going to get seen in a timely fashion. And I think you said there was one occasion where it had been, 12 months late?
Yes, so I saw a client just the other day who he had been referred and he rang the service and he was told that it was newly diagnosed with type 2 and it was a 12-month wait, and he just happened to get on Google. And I think hopefully there are some slides where how to access the allied health outside of that. And I guess, again, it's about the language that we use, because when you're not working in those settings of the big hospitals or the DP pluses, we get called private educators, etc., or private allied health, and that indication would think that people then have to pay these exorbitant fees, but of course it's still covered under Medicare. What it just means is that we're not attached to those big institutions, but they're still covered by the allied health care plans and EPCs, enhanced primary care plans.
Absolutely.
So it's just about how to access that, and perhaps not being told that they have to pay. You know, some of us have like a little gap, because we need to in order to exist, because we're not government funded. Of
course, yeah. And GPs understand that, because a lot of us have a little bit of a gap as well. It's just how it is, isn't it?
Yes, but it certainly means that they're not having to wait a year or 6 months to get some education or to move forward with their health.
Yeah, and that's so important, isn't it? And Jess will be talking a bit later on about some of the interesting, well, diabetes is always interesting, but about some of the slightly less known kinds of diabetes, where you might actually want to start them on insulin very early.
Yes.
And my goodness, I want a diabetes educator to teach those people how to, because I don't think we get much training on it as GPs.
No, and you know, the consequences of either not starting a course or you know, wrong injection technique can be quite challenging.
And we might come back to you a bit later on, because I'd love to hear about some of that.
Yes.
Yeah. Well, it looks as though they're having a little bit of difficulty streaming the PowerPoint, but at the beginning it's fairly straightforward to start with. So we might just start having a bit of a discussion, because otherwise you'll all be here till 9 o'clock tonight, and I think you've all had very busy days. So the learning objectives that we're hoping to cover tonight is, one, to discuss the diagnosis of diabetes. We'll also discuss the treatment of diabetes, and then we're going to examine the referral pathways for a multidisciplinary approach to diabetes. So starting off with the diagnosis of diabetes. Diabetes is essentially a state of insulin deficiency. So it's either because the pancreas is not producing enough, as for example in type 1, or it's unable to produce enough to combat the insulin resistance state, for example in type 2. So the blood glucose is unable to be met by the amount of insulin being produced. Now, we use blood glucose as a measure of our insulin deficiency. We do not measure an insulin level, and there's very, very few indications to measure an insulin level. I'm seeing a lot of people are measuring an insulin. It's $33 to the taxpayer. That doesn't tell you anything. Please don't do it for PCOS. We're seeing a lot of that, and the Pathology Society is actually trying to write out letters saying it's not useful for the diagnosis. And as an endocrinologist, I just look straight over the insulin when I move on. Some people do it to look for insulin resistance, and if you're wanting to look for insulin resistance, you need to do an oral glucose tolerance test. So that's just as an aside.
That's a very useful piece of information, though, because we quite often get patients coming in with a list of the things that they want to have done.
Yeah.
And quite often they get told by somebody they need to have insulin resistance measured. And it's, oh my goodness.
Yeah, so doing an insulin level isn't actually helpful. The only time I do an insulin level is if I'm worried that someone's surreptitiously injecting insulin when I'm working them up for an insulinoma. That's the only actual indication to do an insulin level. And I don't think there's a lot of people worrying about insulinomas out there, but we've got a lot of insulin testing going on.
Thank you for that one.
Not a problem. So when it comes to diagnosing diabetes, you need to think about it first. So you need to work out who you're going to screen. Type 2 is generally more asymptomatic than your type 1 diabetes. And GPs have got this great tool, the Risk, which I don't know if you use, Jackie,
I do.
ever.
I use it all the time. Yeah, brilliant.
And it's to help work out who needs to be screened for type 2 diabetes. I still don't believe our screen's being shared with you, but if you just Google AUSD Risk, it then is available to you to work out who needs to be screened. We calculate this in those who are greater than 40 years of age or greater than 18 if they are Indigenous or Torres Strait Islander. If there's a score of greater or equal to 12, then we think about doing the screening. And people who fill into those populations, we need to think about doing this every year. But if they're at a lower risk, then they only need to be screened every 3 years. Other high risks for screening are people with any cardiovascular disease, women with a history of gestational diabetes, because about 50% of those will end up going on to diabetes at some point in their life. Women with a history of PCOS because of the insulin resistance that they've got. Patients who are on antipsychotics, and that's more things like quetiapine, where you end up putting on a lot of weight.
Olanzapine, that's a bugger for it. Yeah.
Olanzapine is my enemy, but it's the psychiatrist's best friend.
Oh,
so
you know, they're actually moving away from it a bit more now because they're actually starting to realise that it's quite problematic in the longer term. Yeah.
But some people unfortunately really do need it, so we have to deal with the consequences of that associated weight gain. Now, if people are symptomatic of hypoglycemia, you know the standard things that they complain of. It's excessive thirst, passing more urine, feeling tired and lethargic, always hungry, not healing so well, blurred vision, mood swings, headaches, dizziness, leg cramps. So it is worth thinking about screening for diabetes when people come in with non-specific symptoms. So the way we diagnose diabetes is you can either do a fasting blood glucose and or another random glucose. Now, if they're symptomatic, you only need one abnormal result, and it's a fasting of greater than or equal to 7 or a random of greater than or equal to 11.1. But if they're asymptomatic, you need to have 2 abnormal results on separate days. Now, that's one way of doing it. Or you can do the HbA1c test, which is now Medicare approved for diabetes screening.
So, Jess, I know one thing about HbA1c. When you're using it for the women who've had gestational diabetes, there's something about not using it in the first little while, isn't there?
Are you talking postpartum?
Yes, exactly. Okay. Yes.
So we don't use an HbA1c during pregnancy. During the COVID period, we did say that you could use an HbA1c of 5.9 or above in the first trimester to help diagnose gestational diabetes. But that was really in more of a, if there's a panic that there was a huge outbreak, it's not good practice, it's not evidence-based, but it was put there just in case we couldn't do OGTTs. Now, the HbA1c is a glycated hemoglobin. So your red blood cells are turned over approximately every 120 days, and it's the glucose that's adhered to those red blood cells. Now, in the postpartum period, things become a little bit difficult to work out because they have potentially had blood loss. They're making their own blood again, or just during that whole pregnancy state, if they had GDM, is there still an overhang? Because gestational diabetes is essentially the woman has developed short-term type 2. It's a state of insulin resistance, which may resolve by taking that placenta out. It's the placenta that makes the insulin resistance. So that's why we ask people to arrange for a 6-week postpartum oral glucose tolerance test rather than doing an HbA1c.
That makes sense. I do know, and Kirralie, I'm not sure whether you see these women, but sometimes you get the women who didn't come back, or they came back at 6 weeks, you gave them the form to go and have the OGTT, and I don't blame any woman who's got a small baby and doesn't get to do it.
Yeah.
So how long after they've given birth can you safely do an HbA1c and be accurate?
We don't have any studies actually confirming the accuracy, but based on physiology, I'd be waiting at least 6 months.
Cool. That's very useful.
And can I just make the comment that after 11 months, they drop off, when they're registered for gestational diabetes, they drop off the NDSS, because I had a lot of people coming into pharmacy that say, oh, I had gestational diabetes and now I've got another gestational pregnancy and I just need to get some strips. If it's past the 11 months, they drop off the NDSS, so they actually have to be re-registered for that second pregnancy. We're seeing a lot more people come in with their old registration cards saying, can I get some more strips? And they can't. They actually need to be re-registered if it's past the 11th month of that first pregnancy.
Very handy to know that.
Yeah, we're seeing it more and more now. And I don't know whether, again, it's just a time that people are not realising that, but it seems to be happening more and more. So just to be aware of them.
Thank you.
So a lot of shared care GPs request the oral glucose tolerance test. So when you're chasing your results, it'd be much appreciated, particularly for the patient, to complete that form again. And the patient does have to sign it, but when they come back, to make their life a little bit easier. Because they can get testing straight away as they've already been educated previously. They will need to see a diabetes educator again for a refresher, but it's great these women often remember what they were doing and they can get straight back on it, and we can get to medication earlier if necessary.
And there's a case later on that we can talk about. Yeah, exactly.
Yeah. I'm just going to confirm, are we still without our screen? Your screen is showing.
Oh, you can see us.
Hallelujah.
You can see us, or you can see...
You can see both the screen and the presentation.
Wonderful.
Excellent.
Okay, all right. Good. Okay, so as Jackie alluded to, there's multiple types of diabetes. We've got type 1 diabetes, which we're all familiar with. It's an autoimmune condition where there's autoantibodies against the pancreas, which then subsequently results in pancreatic failure. Type 2, which we've got the epidemic for, which is insulin resistance. And you can be a skinny type 2. You don't have to be obese to have type 2. So do think about it. If someone's presenting with typical symptoms, still screen for it. Then we've got LADA, which is latent latent diabetes in adults, which the easiest way to explain that is it's another version of type 1 that develops later. So it's not exactly the case, but it's easier to think of that way. You may have someone who develops diabetes and that you can use metformin for a couple of months and then they rapidly progress over onto insulin and they have similar signs and symptoms of someone with type 1. Now, it isn't exactly type 1 and we're not going to go through all the details today, but just think of someone that if they're not looking like your typical type 2 and they've progressed their disease very quickly, it may be worth sending them along to an endocrinologist to work out whether or not they do have LADA. Gestational diabetes, which we're all familiar with as well, and we do need to remember that a lot of our mums who have gestational diabetes are at risk of going on to develop type 2 and to continue to monitor. Now, one that people might not be so familiar with is MODY.
I've never heard of that one.
So it used to be called monogenic diabetes of the young. It's now called maturity onset diabetes of the young. We all just call it MODY and don't really care what the acronym now stands for, which I'll go through in a little bit, just to give you an idea that there's different diabetes, but I'm not expecting you to be worrying about the ins and outs of it.
I guess as a GP, the thing that I want to know is, how do I pick it? Do I treat it differently? And do I need to send it to you and Kiralee earlier on in the piece?
MODY's quite fascinating. I've seen 2 cases of MODY, and they were quite, I shouldn't probably say that, but they're actually quite fascinating to see, because they behave very differently, don't they?
Yeah. So in the next 2 slides, please pull me up and we'll see if I can explain it a little bit more for you. And then we've got our type 3, or pancreatogenic. It's where you get pancreatic failure, but it's not autoimmune. So our cystic fibrosis patients end up getting what looks like type 1, but it's due to the CF. People with recurrent severe pancreatitis, or if they've had a pancreatectomy for pancreatic cancer.
That one.
Yes, I've lost my tongue. Okay, so the way I educate my patients is, if they're a LADA or a type 3C, I tell them, if they ever go to hospital, say that I'm like a type 1, because there's a lot of hospital doctors that don't know the difference as well. And so it's very important that they don't then have their long-acting insulin ceased, because they'll end up in DKA just like someone with type 1 would.
Ah, that's useful to know too.
So treat them the same. So who do you think about and what diagnosis? So if it's less than 6 months of age, it generally gets picked up by a paediatrician, but you need to think about neonatal diabetes. It's a genetic form of diabetes. It runs in families. I've seen a few interesting cases. Sorry for the patients, but I find a lot of medicine fascinating. But it's really diagnosed in that first 6 months. If they have deafness or neurological features, then there's different types of mitochondrial diabetes, and it's worth sending to an endocrinologist, and then we send on to a geneticist to work out. Now, this tends to appear in childhood as well, when they're appearing to have other metabolic abnormalities. So they'll be managed at the kids until they grow up, and then we'll take over. And then we've got probable type 1s, and so they're people with permanent, the need for insulin from diagnosis. They'll often present in DKA, or they have positive antibodies. Now, it's worth mentioning you don't have to have positive antibodies to have type 1, because we don't actually measure for every type of antibody. We just measure for the most common antibodies. But if you do a C-peptide in someone and it's non-existent and they're behaving like a type 1, well, then we can do some more genetic thinking, but we call them type 1 until proven otherwise.
Okay, so C-peptide is the key to this?
Yes, so this is where I was saying that we don't do insulin levels. So your insulin molecule has 3 chains to it: an alpha, a beta, and then a C.
There's another name for that, isn't it?
Yeah.
Gamma? No.
They tried to be clever and then gave up. And so as it folds over, the alpha and the beta join with disulfide bonds, and then the C-peptide's cleaved off. So when we do blood tests, we measure to see how much C-peptide there is, because that will give us an idea of how much endogenous insulin is around. It lasts for a couple of hours, where insulin is momentary and it's constantly changing. So if you do an insulin level, where we know how much insulin is at that very moment, but unfortunately we do have patients that will self-inject with insulin. So we don't measure insulin levels, because we don't know if they've self-injected. The C-peptide would tell us about their pancreatic function.
Is that your insulinomas that you're talking about?
Yeah, those kinds of things. So you're having people who keep having hypo symptoms, and it's part of the workup for that. So we do see peptides there as well. So when you consider MODY, it's if they don't really fit into a type 2 and they don't really fit into a type 1. So if they're less than 30 years of age and they've got a raised C-peptide, i.e. they're still making insulin, they don't have any appearance of insulin resistance. Now we do have to remember you do get your skinny PCOS, you do get your skinny type 2s, but that's when you need to start thinking about it. And MODY is an inherited. Now you can always have the first case in a family, but you need to think about, their mother and their grandmother were both diagnosed with diabetes at an early age, then specifically below 45, maybe we need to think about a MODY, and you can send them through to us as an endocrinologist. They end up needing to be seen by the Royal Adelaide Genetics Department if they're not going to pay for the testing. It's about $1,000 otherwise. So we tend to put them in there once we work them up and feel that the probability is there.
Because once they've seen the genetic counsellor, then they can access a Medicare rebate. Is that how it works? Or
no, the artist pays for it.
Okay. Yeah. And Kirili, you said that you'd had a couple of these MODY people.
Yes.
Did they have family histories? Was that what you saw with them?
One had a family history, but it was really interesting in that she told me she was diagnosed as a child, but never put on insulin. But she was quite old with respect to older than 30. She was about 42 when I first saw her. But she kept telling me she was put on insulin to try and bring her HbA1c down. The really interesting thing is that she kept telling me the more insulin they gave her, in her words, the worse her diabetes became. So I sent her immediately to an endocrinologist, and he suspected that she had MODY. So she sent him on. He sent her on. It's quite interesting.
Is that a typical feature that when they have the more insulin that? Sorry to put you on the spot, Jess, but you're looking very puzzled about that thought.
I think that I wouldn't be actually needing to see the true numbers rather than just a description of the more insulin I get, the worse my diabetes gets. I think there might have been an underlying pathology or something happening at the time. It's not something that is a typical feature of MODY, no.
Yeah, the really interesting, like I said, the really interesting thing was that she kept saying I was diagnosed quite young, but I didn't need insulin. And we're talking kind of 30 years ago, when really type 2 wasn't around a lot. But she kept saying I didn't need insulin, I definitely didn't need insulin. So that's when I kind of went, that's kind of odd.
And I think that's what you were saying, that when it sort of doesn't fit, that's what you're looking for, isn't it?
That's what we're looking for, So in all, there's about, I think there's 11, I can't remember counting recently how many different types of diabetes there are, depending on which mutations and things everybody has. But so there's more than just type 1 and 2, but the easiest way to think of management is, are they more like a type 1 or are they more like a type 2?
Thank you, because as a GP, my head is now exploding.
Don't start memorising all the different mutations. But I just thought, because you were looking for some guides where things weren't quite right, just a couple of different types of MODY. So the most common one is where you have a normal fasting but an elevated postprandial. Now, I was part of a study when I was working in Queensland, because we think that we've actually got a lot more MODY than actually there, and we can pick it up during pregnancy with the oral glucose tolerance test, because everyone's having them done. We've got a normal fasting and elevated postprandial, but that study is still going on. What we know is, yes, so their fasting's normal, elevated postprandial, but they do have glycosuria with a normal BGL. These people we treat with sulfonylurea, like a glycoside first time, but they will often end up needing to go into insulin, and they have the same micro and macrovascular complications. MODY type 1 is very, very similar to type 3. Then there's another one where type 5, where you get not only your diabetes problems, but you get exocrine problems as well. So it looks as though they've had recurrent pancreatitis, but there's no history of pancreatitis. And then you find out they've got kidney disease, they've got uterine abnormalities, gout, abnormal LFTs. It's just a picture of things just not quite fitting. And the one that we take most seriously is the GCK type, where they have this very mild hypoglycemia since birth. And I've diagnosed a couple of these where they've been sent in because their GP's randomly done a glucose as part of their annual screening.
Yeah.
They're quite young. They've got these persistently elevated fasting blood glucose level, but then when you do their HbA1c, it's not too bad. They don't look like they've got type 2. They say, oh, I think my dad had this or something. This is kind of the very typical story I get. Now, unfortunately for these patients, they do have to declare themselves as having diabetes, and so that does go against them for things like declaring on insurance and those kinds of things, which is where I've had issues with patients before. But I've tried to explain to the health insurance and the income protection that they're never actually going to get any micro or macrovascular complications. What this type of MODY is where they've got an incorrect set point. So where we have a fasting of somewhere between 3.5 and 5 as being normal for us, their fasting normal is 5 to 6, say. So they always have a 6, but their whole body has been wired so 6 is normal.
Yeah.
And so that can be important during pregnancy as to whether the mum's got it, whether the baby's got it or not. But yeah, if you're finding that someone really doesn't look right and you keep doing these like fastings and they just keep being a little bit elevated, and someone like their mum or dad's been the same and never had any problems, then this might very well be that thing.
And you know what, Jess? At that point, I think I'm going to be sending them to someone like you.
And I think that's not a wrong thing to be doing at all. All right, so I'll just skip over this one. It was really just saying that there's lots of different types again. But I thought we'd get on to diabetes treatment, particularly because we've got Kira Lee here today to help us go through all of that. Now, the first thing I did want to say is non-pharmacological therapy is always first line. If you've got type 1, okay, insulin's first line, you die without insulin. But any other form of diabetes, particularly if there's weight and diet-related components, you very much need to address those. And that's the hardest to address and the ones that patients really don't want to, which I can understand. But, all right, so why do we treat? We are wanting to control the blood glucose level to reduce symptoms, which is what patients worry about. What we tend to worry about more so is prevention and treatment of long-term micro and macrovascular complications. And control of blood glucose concentrations early after diagnosis may prevent particularly macrovascular complications later on. So it's not just about getting a nice number. There is reasons why we want that nice number. And I find I do a clinic that Jackie's aware of at the Sefton.
I love your clinic.
The Sefton Park Intermediate Care Service. It's the Royal Adelaide Max Clinic, where I see a lot of complex care patients with lots of comorbidities, often social, psychological as well. And the one thing I see with these patients is that they often haven't had things explained to them, and they're very resistant to taking any of their medications because, well, why do I need to take it? I feel sick when I'm on my metformin. If I take it or not, I've still got bad numbers. Who cares about the number? So things can't always be done in one consult for myself or in very busy GP practices either. But every time I see someone, I try to impart just a little bit more education for the disease underlying process so they know why they're doing this. Why do I want you to take your medication? Well, you'll feel better on it. If you're sitting with a blood sugar of 25, you're going to feel very lethargic and you're not going to feel very well. If you take your medication to get it to normal range, you're going to feel better. And so they tend to understand that when I'm working with that particular demographic. So I kind of extend it to all my patients. I think education's the key. If you know why you're doing it, then you're more likely to be compliant.
So true. And I've got a patient who knows when her diabetes is out of kilter because her thrush gets worse.
And yeah, that's exactly right. So patients are very good at working out what their signs and symptoms are as well. So once again, why are we wanting an HbA1c of 7%? Is it because some crazy endocrinologist just likes numbers? Well, we do like numbers, but the reason behind it really stems from two trials that were done back in the 80s, 90s. The first one is the DCCT trial. It was looked at with type 1 patients specifically, and they compared an HbA1c of 7% to 9%. And this was over 6.5 years. And what they found was that all microvascular complications reduced, but most specifically the retinopathy really reduces. And then they followed these patients over 20 years with no further intervention. And they found that those that were in the intensive group, where they had dropped their blood glucose levels lower faster, had persistent benefits over 20 years. So we'll talk about this more with treatment, but this really enforces insulin is not the last line of treatment. We want to get patients onto treatment and best treatment early. Referring to me after they've had 10 years of poor control, they've now got 10 years worth of higher risk of micro and macrovascular complications. So we'll talk a bit more about that later, but this is definitely indicating the legacy effect. And the other one was the UK PDS trial, which was done in type 2 patients, where they were on insulin and or sulfonylurea to have, once again, an HbA1c of 7%. Now, we did see in this trial as well that there was a reduction in microvascular complications, particularly retinopathy again. So whether your patients have been diagnosed with type 1, type 2, or any of those other ones, it is worth trying to keep the HbA1c around 7%. Jumping over this one, that was that legacy effect that I was talking about, which was also shown with the UK PDS.
I like this one. It's got colours in it.
I just needed colour because I figured everyone would be asleep by now. But the question is, should we be aiming for an HbA1c of 7% in everyone?
Good question. Yeah, I've often wondered that myself.
And the answer is very simply no.
Good.
So if you have a woman who's pre-conception with any form of diabetes, I really want an HbA1c as close to 6.5% as possible. If they've got type 2, then they can quite easily get to that 6.5% safely. If someone has type 1 diabetes, well, then their hypoglycemic awareness and how frequently they hypo means that we try and get as close to 6.5 as is safe to do. And some women just can't drop below 7 because they have too many hypos, and that's fine, and that's what we work with.
Do you find, is that what you tend to find with your women as well, Kira? Yeah.
I also find it really interesting that people don't equate that percentage. And I know we're supposed to swap over to the international standards.
Oh, yes, that's right.
Yeah, New Zealand did years ago. Australia never will.
No. But you know, people think that HbA1c is 7% or 8% of the blood glucose level, and I have to spend 15-20 minutes explaining that 8% is not their blood glucose, is not their fingerprint.
Yeah.
Yes, because I find it really interesting that they go, oh, well, my HbA1c is 8%, that's okay, isn't it? And I have to explain that actually no, 6.5% is probably very close to your fingerprint, but 8% is actually not.
Yeah.
And that can take 15-20 minutes for them to kind of get their head around it. Because they're often coming in saying, and I say, what has prompted the referral today? And they say, well, they're telling me my HbA1c is not okay. And when I look at it, I say, well, it's it's 8.6 or it's 9%. And they go, yeah, but that's fine. That's what's wrong with 9% or 10% or 11%. And so then we have to have that whole discussion. So it's quite interesting that that percentage, which again was supposed to be the swap over, that won't happen and probably will never happen now.
Yeah, and changing over they're still not going to be quite equal. I talk to my patients about units. One's a percentage, one's millimoles per litre. If you're jumping over, then it's millimole per litre. So it's still not going to be exactly the same. So patients tend to understand that you're not comparing apples with apples. And as soon as I then convert it over and go, oh, your 8% means you're probably sitting around 13 to 14 most of the time. They're like, I am. I'm like, yes, so there we go.
Jess, that's brilliant. Is there something I can use in my practice that I can because that's actually a useful thing to be able to do, isn't it?
So correct me if I'm wrong, but you double the HbA1c in take 2. Is that right?
I think you might be right, but I use Google.
Okay, folks, you've heard it from our guys here. Google.
So I just type into Google HbA1c millimole per litre conversion, and there's lots of very good websites where you just type in the percent and it spits it out, because I spend so long memorising certain things that's one I haven't committed to memory.
Yeah, I'm almost 100% sure, but again, I could be corrected. But I'm pretty sure you double the HbA1c you take 2.
I think that might be.
So 9% is 18 minus 2.
Which would give us 16.
Roughly at some point in the day.
Which is what I would say is about 16.
So if someone wants to Google it and pop it up, is 9% a rough blood glucose level of 16 and pop it up on that answer? If someone wants to Google it.
If you're on there,
just to see whether I'm, a little bit right. I don't know, can you be a little bit right?
It will be a really easy way of doing it. So I have to test this out.
Yeah, exactly. So part of the reason as well that we don't really aim for going much below that 7% is based on the Accord study that was done in the early 2000s. This included people with type 2 diabetes that had some kind of cardiovascular or macrovascular complication. They followed them up over 3.5 years, and they kept them really tight control. So they kept them down to 6% or below. And there was actually an increased mortality rate. So the study was cut early. And so part of the reason, so there's the increased mortality that we showed. But it's your hypoglycemia, it's very dangerous. And a lot of my patients are very scared of it, which is when they get referred to me. Patients refusing to go on insulin, please talk to them. And it's got a lot to do with the hypoglycemia fear. So they feel really awful, and particularly when I'm educating my new type 1 patients, I'm like, have you had any hypos? They're like, I don't think so. I'm like, trust me, you will know when you have your first hypo, you will feel awful. And I go over hypo management with them every time until they've had their first hypo, because then they always mismanage their first hypo because they feel so awful. I say take 15 grams of carbohydrates, and they've pre-set out their jelly bean container, but it doesn't matter. They still eat the whole bag the first time because they just feel so scared.
Ooh, Daddy Byrne has given us the answer. Daddy, it's gone.
It's hot.
Where did it go? Bring it back. He worked it out for us. Thank you, Daddy. There you go.
It comes up in that history.
Yeah, that's all right.
Yes.
We trust whatever you said. And thank you for checking that out for us. So yes, they've eaten the whole jelly bean bag.
Because they felt as though they're going to die. And so hypos are really scary, and particularly people with some degree of intellectual cognitive impairment. They struggle the worst because they can't often equate I just have to have my 15 grams, wait the 15 minutes. It's okay, I can wait 15 minutes. They are going to go all in, and while they're waiting that 15 minutes, they're continuing to eat their bag of jelly beans, and then you get your massive overshoot. And so, you get your yo-yo effect where you go really high, and then they go, oh no, I've had too many jelly beans, let me take some insulin, and then come back down, and then they hypo. And so that's where getting the right doses of insulin and good hypo management really works. Just speaking of hypos, a lot of my patients end up making individual hypo bags. I tell them just to have a Ziploc bag of their favourite choice of 15 grams of quick-acting carbohydrates. Some people like jelly beans, some people like snakes, whatever they like. And sometimes I even get patients to put things they don't like in there because otherwise they eat them. They eat them.
Yeah, yeah.
They eat them, I know. And I remember going out with one of the school mums one night who had diabetes, type 1, and sitting in the performance with her and her whispering to me, have you got any snakes or sweets in your bag? And I'm like, what are you talking about? The kids had eaten all the sweets.
Yeah.
Yes, yes.
Yes.
So you have your 15 grams of quick-acting carbohydrates. You wait your 15 minutes. Then you check your blood sugar again. If it's above 5, then you know you're starting to get into safe territory. And then you have 15 grams of long-acting carbohydrates. In the hospitals, that's three of the Arnott's biscuits is just over 15 grams. So we say to have one of those. And on that, our PowerPoint presentation has just
Disappeared into smoke. But that's okay, because I was going to ask Kiralee if you do anything differently with your management of hypos.
Unless you're on an insulin pump, then you don't give the long-acting carbohydrate because they've only got the short-acting insulin in their pump, so they just need to treat with short-acting carbohydrate, nothing else. The really interesting thing is sometimes with those really quite severe hypos, you get the rebound cortisone and adrenaline coming in, and that can push them up as well. So people can get really frustrated because they're doing exactly what you're saying, but they'll still rebound. And so sometimes being aware that the cortisone and the adrenaline and noradrenaline is kicking in and pushing them up, and then they can again be very insulin resistant for 24 to 48 hours afterwards, and so then they'll over-treat again, as you say. So we just have to educate them about making sure that they're not giving extra insulin, and just continue with the insulin, correct? Just to give the insulin that they're used to. Otherwise, again, then they just start to have this yo-yoing effect. Yo-yoing is very difficult, isn't it, to treat? You just have to let that first hypo. The rule of thumb is to fix the hypos first. If you can fix that, then everything else starts to calm down a little bit.
And being very empathetic and understanding to your patients, I think, is also very important because they're really scared when they're going through these hypos, and just that's why I find getting them to make their hypo kits up, then they feel a little bit more in control because they know that they have to consciously make a decision to open a second Ziploc bag of jelly beans. They know that they can do that if they feel that they really have to, but it's just taking some of those steps.
Can I just ask, glucagon, where does that come into it?
So glucagon it tends not to be administered by the patient themselves. So glucagon gets converted into, your glucagon is used to convert your glycogen stores in your liver into glucose. Now, it often tends to be used by another person, so we always make sure that there's the school's educated, the husband or wife, the kids are educated, so that they can administer it if the person with type 1 is unable to. It's generally reserved for severe hypoglycemic episodes where you can't manage it yourself, and we get patients to have it on hand. Now, it does really only have a shelf life of about 12 months. Kiralee might be able to correct me.
12 to 18 is
So I don't necessarily make every patient have it if they don't get hypos or they get they have very good hypo awareness. I tend to recommend that they have it, but if someone's had glucagon sitting in the cupboard for 10 years and never used it, and they said, I'm just not going to buy it anymore, I don't argue with them over it. But I always make sure it's available when children have diabetes. Now, you have to remember that you have to have glycogen stores to convert into glucose. So people with liver failure often don't work so well, and in hospital we just end up putting them on straight glucose to happen.
We'll get to this question in a moment, but we've just had a very interesting question that if a person has a very high hemoglobin A1C at diagnosis, would you consider starting 2 medications at once? And I guess that's timely because we're about to get onto the oral hypoglycemics.
So the best HbA1c it used to be sitting on my office wall in Darwin. I can't remember what it was now, but it was in the 20s.
Oh, you beat me.
Yeah, no, I think it was, I can't remember if it was 20.5 or 25. I remember there was a 2 and a 5. And I used to have a rule where as long as their blood sugar, as long as their HbA1c was less than 15%, I knew they were taking something, which is a very poor way of looking at things. But the group of patients I was working with at the time, I was really just wanting to know, are you taking your medication or not? But we're going to talk about the type 2s rather than type 1s, because insulin is your answer for type 1.
That's true, isn't it?
So metformin is the first line, and it still is the first line, and I think that everybody should go on to metformin, and only if they don't tolerate it to then stop it. So the way that I find patients best work with metformin is starting at 500 milligrams and up titrating no faster than every 3 days. So 500, then 3 or 4 days later, adding on another 500, moving up till you get to, say, your 2 grams. And that's even if someone's been on metformin for quite a while, and then they had to stop it for some reason. Like they were in hospital, they were having prolonged fasts, they had a cabbage, something that prevented them from being on it. I do take it back up again, because you don't want to make someone have diarrhea or tummy cramping by going on to a higher dose. So if someone comes in with an HbA1c of 18%, yes, I want them on 2 grams of metformin. There's no point just hanging around to that 500. But I do it every couple of days, and I find patients often start better with a nighttime dose, and I tell them, try taking it when you go to bed, because then they often don't notice the adverse effects.
Yes.
But some people do better with an evening meal. So I give them the option. I say, try taking it at bed. If you feel queasy when you take it at bed, move it to having with your dinner. And I will start with BD. So I'll go 500 in the at night, then 500 in the morning, and build it up. And then I'll change them over to once a day. But I find it has much better tolerance if you're giving it to them that way.
Okay. Because I was going to ask Kiralee about because there's the extended release ones, and I'm never quite sure what to do, whether you go extended release or short acting. Is there any sort of guide about that? Or?
Not really. Most people tolerate the extended release better because it moves through the gut into the small intestine, and it's released from the small intestine. So most people tolerate the XR or the MR much better than they will the quick acting. Much better.
I find the same. They do tolerate it better. It is more expensive though. So if they're on a healthcare card, it doesn't really make much difference. But sometimes I have patients who they don't fall into that concession card, but they're still struggling financially, and how to try and change some of their medications up. If they've had no signs or symptoms, then I'll put them over onto the regular immediate release, because it is just a little bit cheaper. I guess you do pharmacy shop perhaps for these patients as well, but that's a general.
Well, it's a thing that you could talk through with your patient, isn't it?
Yeah. We're seeing a worldwide shortage of metformin now.
Yes, I've heard that. Yeah, I've seen it actually.
And the reason for that is that it's so cheap. And I understand what you're saying about the difference, but it's so cheap that we don't make it in Australia. We don't make many medications in Australia. But there's only 2 companies in the world now making metformin.
Seriously?
2 countries making it, and so now they're holding most countries to ransom over metformin. So we're seeing short supply on metformin, whether it's extended release or from immediate release. So we're pretty much getting whatever we can at any time that we can get it. So most GPs we're getting phone calls. Can we swap the person from metformin 1,000 milligrams to 2 metformin 500 milligrams? The pharmacy board have allowed pharmacists to now swap and just endorse the script, as long as we're going out and saying to the person, you used to be on 1,000 milligrams one a day or one at night. You're now on metformin 500 milligrams, and maybe the next time you get the script, you go somewhere else. So we're just swapping and changing to whatever brand and whatever we can get, as long as we are clear with the person.
Sure.
what they're getting and how they're getting it, as long as we're keeping the supply up. And we've seen a little bit better supply coming through. But I think this will be ongoing forever.
Yeah, we're having a lot of difficulty accessing cheap drugs. All right, now, was there a question?
There was a big flush up, but I didn't quite catch what it was. No, it's okay.
All right,
Oh, good. Okay.
So I'm going to talk about the different drugs, and then we'll talk about how we order them. With metformin as well, metformin on its own won't cause hypoglycemic episodes, so that's something to be aware of. Now, the next group is your sulfonylureas, which is most commonly glycoside. You do still see some patients on glucosamide and some of the other more older-fashioned. They're all much of a muchness, but glycoside really seems to have market share these days. This is where the glycoside molecule binds to the receptor on the surface of the beta cells in the pancreas and triggers them to release insulin. So you have to have some pancreatic function for the extra insulin to be released. And so you end up with an increase in glucose-independent insulin secretion. So if you don't eat, you're still going to have that extra insulin being produced. So this is where people always tell me their horror stories of having hypos when they've been taking their glucoside while they're fasting and things like that, and then they end up with bad hypos. Now, glycoside is great in the early stages. I think of it as a bit like a poor man's Novorapid, kind of, where it kind of helps with that little bit of extra insulin secretion and can often get people like they don't have to go on to Novorapid quite so early because they're still having enough of that extra insulin available. But the really important thing to say is it pushes the pancreas harder. So you do end up progressing the diabetes faster. Now, in some patients, that's not going to be a problem. In some patients, it ends up being a problem. And the others, and sometimes I see people coming in on glargine and Novorapid and still on glucoside. And if you're at the point where you're needing so much insulin when you're on the Novorapid and the glargine, your pancreas isn't working effectively. There's no point flogging a dead horse. Stop taking the glucoside. I always cease it once I've got them onto a basal bolus or a BD mixed insulin.
That's a good tip.
Yeah. Don't know if you've got anything, Kiralee, you wanted to add.
It's interesting because I had a HML pharmacist, home medication pharmacist, do that to 2 people in the nursing home.
Yep.
She did exactly that, and their blood glucose levels skyrocketed.
Really?
So, because that's always what I've learned, and so then I was called in as a diabetes educator to then oversee their medication. They were both interestingly just on glargine. Stabilised blood glucose levels okay, and she did that. The recommendation was to stop the glycoside because at the other point of that is when people hypo, you kind of don't know which one's causing it. Is it the insulin or the sulfonylurea that's doing it? So she made the recommendation to cease it, and both of them, the first one they kind of went, oh well, it's obviously just circumstantial, but the second person did exactly the same thing. So there must have been just that small stimulus happening. Both of them were elderly. So
just a little tiny bit of pancreas still.
Obviously just a little bit of stimulus. I mean, my recommendation was not to put them back on that for the very reasons that you've said. We ended up, I think, putting them on the DPP4 because they were, when we did the traces and stuff, they were high after meals. So that was the obvious choice from an elderly perspective. And they settled back down again. But yes, that's what, but both of them did it.
Yeah, and it would depend, and I would be interested to see how much glargine they were on. If they were on 8 units or 10 units, then there will be some pancreatic function.
Not a lot. So good point. Yeah.
Whereas if you've got someone on 40 or 50 of glargine, then they're needing a lot more than someone on that small amount.
Yeah, from memory, one was only on about 8 and the other one was only on about 12. So not a lot. So it probably was doing a little bit of stimulus of the pancreas still. Yeah.
So I don't want people to think of glycoside as being something that is a glucose dependent where it reduces post meals, because it definitely doesn't.
No, yeah.
But in practice, I do see it's that kind of do I need to put them on Novorapid? Do I not? It's often the glycoside that can hold them if I don't think that they definitely have to go on to Novorapid.
Yeah, that makes sense.
Yes, it
So-
does make sense. That's very useful.
Yeah.
So the next class is thiazolidinediones or your pioglitazones. Now, these aren't used very much these days after the rosiglitazone episode back in about 2007. I think the TGA registered it as causing cardiac issues. But pioglitazone doesn't have the cardiac issues, and you can use it. We still say avoiding heart failure though. But this is, it works on the PARP. It prevents the PARP ligand from promoting insulin release, and so basically it increases glucose uptake into fat and muscle and decreases glucose breakdown from the liver.
Okay.
So it's an alternative to metformin.
Okay.
So it reduces your fasting, and it's actually can be quite good at reducing HbA1c up to about 2.5%. The problem is unlike metformin, which is weight neutral, pioglitazone increases weight. So sometimes I don't use this very often, but if I do have someone with very clear insulin resistance and I'm trying to reduce the amount of insulin or not necessarily have them go into insulin, and they're not really overweight to start with, but I do warn them and I do monitor their weight and see. So they do have a role, but not very common these days.
Okay.
Anything to add, Kira?
No, I see it probably once every 2-3 years.
Yeah. So I don't start it a lot, but
I never remember they exist.
yeah. The next is your acarbose. Now this is one that works on your postprandial, and it's very good. It delays carbohydrate absorption, so it slows your gastric emptying. It slows that whole process down. So then you don't get that massive DGL spike postprandially. The problem is they fart like a trooper.
It's the Xenical of the carbohydrates.
Yeah.
Excellent.
Yes, it's the way of bringing it out.
Yep.
Everyone's around remembers Xenical.
Oh, I remember Xenical,
Yeah.
right? Yeah. Yeah, you could tell if they were taking it because they all got oily diarrhea.
Is it Orlistat? Is that
That's
Yes,
okay.
that's
Sorry.
Oh, yes, sorry.
Sorry.
Yeah. Two pharmacologists either side of me here. You know?
Sorry, I intentionally never learn any trade names. I just sometimes pick them up. So I remember having an older gentleman come and see me in his GP started in 20, 30 years ago. I said, would you like to change it? And he said no, but I had to air my room out afterwards. He didn't have a problem. His wife had died, so she no longer had a problem.
Probably died of the smell.
So some people, it works really well, but it does tend to be that flatulence that causes the problem.
Maybe pick your single patients for it.
Yeah, so
And if they're on any form of medication that causes hypos, they do have to treat their hypos with sucrose. Is it the sucrose or the glucose? I can never remember. It delays glucose, so they have to treat with sucrose. Or
I'm not certain.
Oh my goodness, there's something we'll have to look up and
yes,
tell you later, isn't it?
Yes,
Yeah.
I can never remember.
I'll write it down.
Because that's because I don't actually prescribe it.
Look,
It tends to,
don't
it's
quote
an
me,
old
but I
drug,
think
isn't
it's
it?
that you have to treat with sucrose because it delays.
all right, you
I'll
can get
bring
back
that.
to us
Yes.
as we keep going.
Kimberly is checking. Danny, you don't have to this time.
So we're on to our newer class. And so we've got our GLP-1 agonists. So these result in glucose-dependent insulin secretion. They reduce glucagon secretion, slow gastric emptying, and increase satiety. So they sound really great.
They do.
They do reduce your fastings and your postprandials, and it's rare to get hypos with them. But I do want to stress that a lot of people are actually GLP-1 agonist resistant. And so I've had a patient that I've seen recently not one of yours, Jackie,
Oh, thank God.
where I'm actually going to stop their exenatide because they've been on it for years. They've still got very poor control. They're trying their very best and they didn't notice any great difference on it. So I'm just going to stop it and see what happens. And if all of a sudden their BGO is double, well then, okay, I know that it works. But there's about 20% of the population that won't respond to a GLP-1. So if you're not seeing a benefit, just stop it.
Now, I'm going to pollute the discussion for a moment for the GPs out there who are not as good at generic names. This is what I think of as Byetta and
Bydureon.
Yes, thank you.
Yeah.
That's good to know.
So,
sorry, guys, but I just had to know the tone.
Thank you for reminding me that I speak a different language. It's because I work with pharma and I refuse to give them the credit of their specific names when we've got generics available.
And fair enough too.
So as far as prescribing with insulin, the only GLP-1 that is PBS approved is exenatide for the Byetta twice a day. If you're wanting to put them on the dulaglutide, which is called Trulicity, or the semaglutide, which is, I have no idea.
It's the new one.
It's the new one.
Starts with an I.
Oh, golly. No, it doesn't start with a golly, but I can't read.
Anyway, if you want to put them on anything that's a once a week, you can't combine it with insulin on PBS. And so that's something that you need to be aware of. Now, we've got our DPP-4 inhibitors, which are essentially your weaker version of your GLP-1 agonists. The reason is you have a GLP-1 that goes and has all its effects, and when you're giving extra hormone, think of it that way, you're going to have extra effect.
Okay. Yeah.
Whereas you have DPP-4, which goes around breaking up GLP-1 all the time. So a DPP-4 inhibitor stops that breakdown of GLP-1.
Okay.
So what we're doing is letting the body have its normal amount of GLP-1 again. So rather than giving someone extra GLP-1, they're now just being allowed to have their normal baseline amount without being broken down. Patients do like the DPP-4 inhibitors better than the GLP-1 agonists because they're not injectables, but they aren't as effective. And I do just want to point out with both the GLP-1s and the DPP-4s that one trial did see a signal with an increase in pancreatitis. Yes. Now, if someone has a history of pancreatitis, we won't prescribe it. But if someone's never had pancreatitis, I do prescribe them. They also there was a very weak signal with pancreatic cancer, and in post that was called the I've lost my words now.
You can remember the names of the trials.
In our post manufacture studies, what are they called? Your phase 4 studies.
Okay.
So we haven't had a signal with it. So if someone's got a strong family history of pancreatic cancer, then I avoid it, but otherwise I don't tend to worry. And the other one is there was a signal for increased medullary thyroid cancer. So anyone with a family history of that, or a history of men, which is multiple endocrine neoplasia, I avoid it in them as well.
Okay, cool.
But most people, they're okay. Now, my favourite one, but the one that causes the most problems, are our SGLT2 inhibitors.
I like those ones too.
Yeah. So we find that we're probably getting less episodes of euglycemic ketoacidosis with better education, particularly of GPs who can now educate their patients. So what happens is you just weigh out your sugar.
Yes.
And you end up losing a little bit of weight because you're weighing out some calories. But I explain to my patients, what do bacteria like to eat? They like to eat sugar. If you're weighing out your sugar, then you're at a higher risk of candidiasis and UTIs, and that is a real risk. So if a woman has regular UTIs, I say no. If a man has a history of having a UTI, I say no. But some people are so determined to try that we give a trial and see whether or not their UTIs and candidiasis return.
Yeah. And that lady that I've referred to you, and we'll come back to you in a moment, Kira, because I'm very aware that you've Googled this. But the lady that we talked about.
I stopped on Tuesday.
Yes, you stopped that. You stopped that. Yeah, because she's getting terrible recurrent thrush.
Yeah. Do you think that some of it, though, the thrush and the UTIs, is simply because of the elevated HbA1cs? Because isn't that a sign of diabetes anyway?
So you get the polyuria and the glycosuria when you do have poorly controlled, but we see it way above and beyond. So it's quite significant where they have no history of candidiasis, and this poor woman's coming in, she's like, I've just bought all the Canastin in the it's in the pharmacy, and they've never had it before. So it's definitely true for this class. Now, the one thing that's really important to educate your patients is that they're going to keep losing their sugar through their week if they're eating or not. So if they're fasting, they need to stop it. If they get vomiting and diarrhea where they're not maintaining their oral intake, they need to stop it.
Oh, I see. Okay.
So the anaesthetists now insist that the SGLT2s be stopped 3 days prior to surgery. I'm a little bit more relaxed, but they're the one that's got to put them to sleep, so I respect their 3-day. The Endocrine Society and the anaesthetists differ slightly, but that's fine. So I tell anyone, if you can't keep your food down or you're not eating, stop it. And people will get their empagliflozin and their metformin together, which is called Jardiamet. No?
You'll know better.
Jardiamet.
Yes, Jardiamet.
Okay, all right.
Because Janumet is the other one.
Yes.
So
if it's the empagliflozin or the dapagliflozin mixed with metformin, we shouldn't really be having metformin if you're unwell anyway. So I don't see any problem with stopping it. Now, we did see a lot of patients coming in with euglycemic DKA, so a normal blood sugar, but the elevated ketones and the acidosis when they were taking it, because they're continuing to wear out their sugar. So they're keeping their blood sugar in the normal range, but they go into starvation ketosis because they've got no food available to them because they've weeded it all out. That's probably the simplest way and easiest way of describing it. So I just make sure my patients always stop it when they're unwell. And if I can't trust them, then I don't put them on it. So if someone's got dementia and they're at home and they can't really be kind of trusted to not just keep taking all their tablets, but if someone's got dementia in a nursing home, well then that's easier. You just hope that the nursing staff will stop it.
Yes, and you haven't got the agency nurse and it's all being communicated properly.
Yes. So,
the other thing that I find really interesting is that I often see an SGLT2 started when they're on insulin and the insulin level's not lowered, and so then they start sliding slowly but gradually into a hypo, often seen overnight. So I see a lot of hypoglycemia episodes overnight. HbA1c is still sitting where they need to be, or sometimes it's 6.5 and they've had diabetes for 20 years because an SGLT2's been started and they start waking up with headaches. Classic hypoglycemic episode overnight. Because an SGLT2's been started.
Why would you, now this is going to sound like a very silly question to you two clever ladies, but from my point of view, if once they're on insulin, why would you add in an oral hypoglycemic? Because that, to me, doesn't, and I don't know about the other GPs out there, explain this to me.
If the HbA1c is slightly elevated, like if it's 7.5 and you just want to get that HbA1c down to 7, but of course it can often drop out a whole %. So the insulin dose needs to be dropped that little bit just to bring them back up. Slightly.
So once you go onto insulin, I tend not to then add an oral because the insulin is the key that's missing. But The SGLT2 inhibitors, I'll stop quoting trials, it's okay, where they looked at cardiac and renal benefits, and it's beneficial in heart failure. My greatest problem is stopping the cardiologist from starting every single patient on it, whether or not they've got diabetes, but it's the heart failure benefits. So, and we're also seeing that there's some renal benefits. Now, talking about the kidneys, yes, there are some renoprotective effects, but how does this drug work? It actually gets into the urine and then affects the proximal convoluted tubule from working. So if you're not making any urine, if your kidneys aren't working, then you can't wee anything out. Yes. So the AMH says that you need to stop using it from what did it say?
EGFR.
Yeah, an EGFR of 30. And it's not actually, that's not because of adverse events. Like with metformin, we say that you need to reduce it down based on the EGFR. It's more to do with the pure efficacy, that there's no point taking something. If you can't wee, you can't wee out sugar. That makes sense. So now we do very occasionally use an SGLT2 in someone with type 1 diabetes, but that's very, very specific cases. So if you see it, we haven't gone mad, but there would be a very specific reason for doing it, and the patient would receive lots of education about it.
I get it.
Back to Kiralee, you've done some
I
Googling for us.
Yes, I have. So if the person is using Acbose and suffers a bout of hypoglycemia, the patient must eat something containing monosaccharides such as glucose tablets or gel.
Okay.
Yeah.
Okay.
Cool. It's because they can't, they don't break down the carbohydrates.
Yeah, disaccharides or polysaccharides.
So this is from the Australian Diabetes Association, how it kind of ranks as a hierarchy of medications. First line's metformin, so I didn't bother putting that on because we're going to start everyone on metformin unless we have a really good reason otherwise. And you used to have to go to gliclazide as a second line.
That's right, yes.
You no longer have to, but I often find that gliclazide is actually still the best second line agent.
Okay.
Now, the really important thing is to work out what's your patient's problem. Is it postprandial hypoglycemia? Then something like a DPP-4, that's a glucose dependent insulin secretion and slowing gastric emptying, that's going to be useful. If your patient's got heart failure, then the SGLT2 inhibitor is going to be useful.
Because it will have that extra benefit of heart failure.
Exactly.
Gotcha.
So I always go metformin, then I still go gliclazide, and then I work out where am I going to go. Do I go to DPP-4 and SGLT2 or not? Now, it's important to say that if one oral isn't working, yes, you can add on, but necessarily putting them on every single oral is not going to work. And so I will often stop if something's not having any impact on their blood glucose levels.
So what you're saying is, rather than kind of, end up with 5 different oral hyper that the person's trying to take, you might stop that one and then bolt something else on. Is that correct?
Yes, that's correct.
Thank you.
If I have someone who's absolutely refusing to go onto insulin, then I just keep adding. But then it's more of we're having that education every time they're seeing that adding things on isn't working. And to be honest, a lot of the referrals I get are, I've tried everything, they're on everything, nothing's working, will you please put them on insulin? And I'm very happy to do that. I'm happy to be the bad guy. I think it's really important that patients have a fantastic relationship with their GP, and if it's going to be make and break over insulin, they learn to stop hating me over time, and that's fine. But if you just can't break that barrier with them, then I'm happy to do that. And sometimes there's this funny thing where you go, oh, well, I guess if you're the specialist and you say I need it, it's like, well, your GP knows just as well as I do, but fine, I'm going to use that specialist endocrinologist title and tell you exactly what your GP's been telling you. And it's quite frequent that I then manage to win the battle.
Hey, we're quite happy to use whatever weapons. But I have to say, I think that you two have both said to me that insulin often should be started a lot earlier. And I think that's a really key message tonight, isn't it? Yeah.
And would it, at any point you use like metformin and then as second line therapy, like the I just remembered Ozempic, not that we want to use the brand names, but that's the new one, which is
okay.
or the Bidurans or the Biotas. Would you ever that just because of weight loss?
No, and the ADA doesn't recommend it either. It's definitely in the third line considerations as to where do we go. So, and there is the one now, liraglutide, Saxenda, I think.
Yes.
It's very expensive.
It is.
I had a drug rep come and talk to me. Oh God, I suffered through it. But anyway, and they're like, it's only $300 a month. And I said, well, that's often not feasible for patients. And it's like, well, if they value their quality of life, they'll pay it. And so that can be used as a weight loss agent in people with and without type 2 diabetes. I admit I've never prescribed it because I've never found the right person for it, but no.
But it's I mean, if they've got type 2 diabetes, then you could use one of the injectables.
Yeah. The weight loss with the other injectables is actually not all that great. The drug companies push the weight loss more than it is in reality. Patients need to know that they'll lose somewhere between 2 and 7 kilos. The 7 I've never seen. The 2 is what I tend to see. So they're like, I want that weight loss injection. And you can sell it to them that way, but be aware that you're going to get more of a glycemic improvement than you're going to get a weight loss effect. And if that's all they need to get them kick-started on their diet, go for it. It's great. Anything that helps get people moving. But don't expect them to have a great weight loss. So we've just got a question. Kiralee, you're closer, or Jackie?
Are there any interactions between them? So is it okay to use any combination? And I think what we're talking about here is that's a good question, actually.
So you can use any combination except a DPP-4 and a GLP-1 because you're doing the same thing, and so you're not going to get any additional benefit. Now, PBS has now approved a DPP-4 and an SGLT2, but I think it's only one particular combination. It's sitagliptin and some other one that I've never heard of before because it's not sold as an individual. But otherwise, unfortunately, they're not, I don't think, allowed to be on it otherwise. I find that if they're on an SGLT2 and it's not working, adding a DPP-4 is not going to work, and vice versa. So I tend to really go metformin, glycoside, then I work out, are they going to be better as an SGLT2 or a GLP or a DPP-4? Pick that one. If that doesn't work, then insulin. I don't waste my time throwing other things in because it's not really going to work. And I will often go to insulin earlier if I think I need to, but patients often need to have it proved to themselves that they need the insulin, and they're like, just give me a different tablet, and I will go through that process of doing a couple to prove to them. I may know full well it's not going to work, but I think it's really important to have your patients on side.
It is.
And rather than saying I was bullied into insulin, they can see, and it doesn't take very long to see that it is or isn't working for them.
How long, because this isn't something that I struggle with, how long would you wait with an agent before you decide that this really isn't working for this person, or it's not working as well as I'd like it to?
I give them 3 months. Yeah.
Good.
If you haven't seen a good effect within 3 months, you're not going to. Yeah.
And I find that really interesting. One tool that's really helpful is blood glucose monitoring. And if you get them doing it, you don't have to get them doing it frequently, but twice a day, one before a meal and 1 2 hours after a meal, and randomly going through the day, they very quickly pick up, oh, actually, when I eat this meal, my blood glucose level actually does hit 16, and that's attached to me feeling tired, and that's when I fall asleep in a chair, and actually that's where my aches and pains are worse, and that's when I get cramps. And if you list those symptoms and get them to monitor and get them to attach those symptoms, then they start working out for themselves really quickly. Because they'll explain away all those symptoms. Oh, well, I was tired because I got up in the middle of the night, and I was thirsty because I was drinking more, and that doctor put me on that medication, and she told me that I would wean more out. So they will try and explain all that away. But when you start with blood glucose monitoring, you say, right, write those symptoms down in that book. I give them books. Companies hate me because I'm always saying, give me a book, and it costs them $25,000. And I think, well, you're selling the medication, give me a book.
That's right, exactly. Make the most of it.
I bring them back, and they say, so how did you go? And they go, oh, actually, you were right. These symptoms matched this blood glucose level. And I'm like, so we really do need to start insulin. Are you ready for that now? And they go, yeah, okay. And so then back we go, and insulin starts. Quickly.
Nice tip.
I very much agree. I see the same thing. The HbA1c is fine and all, but I find a lot of people will be monitoring their fasting every day and then do an HbA1c. It's not
match. Oh, my patients all love doing their fasting.
So it's all good and well. Okay, now I know you're fasting, but what happens throughout the day when you actually eat? So I end up in their book highlighting squares and making them do it at different times, and then that's where they really see the difference, because I'm like, okay, yes, I know that your fasting is always sitting between 9 and 10. You're not giving me any additional information by doing it every day. Let's mix it up. And it's also really important to emphasize to patients that they either do it before a meal or a full 2 hours after a meal. There's no point doing it 10 minutes after a meal, 30 minutes after a meal, because I can't interpret that, because the blood glucose is still on its way up. I need to know, has it started to come back down again, and how. So that's where we're at.
That makes a lot of sense. I like the idea. And how long would you guys do monitoring? How long would you get them to monitor for? What sort of time period?
I get them to either do what's called 3-day intense, which is breakfast, lunch, dinner, and bring them back like 2 weeks later. Or if they can't come back for a month, I'll get them to do 2 a day right through until they come back to me.
Yeah, cool.
I very much agree with that. I'm just going to see whether or not we've got a power cord for our computer, because it seems to be dying.
The computer is about to, it says it's running low and you might want to plug it in. I always love the way that they say you might want to plug in your PC. It's like, well, yes, we would. Perhaps if we just keep talking, and if it dies, well, you know, I think Mel is capable of this. We trust her.
So the other thing I get patients to do is to measure their before bed if they're on glargine. Because another tidbit is, you know, they're on the correct dose of glargine if their before bed and their fasting are plus or minus 2. So if they go to bed at 9 and they wake up somewhere between 7 and 11, then you know that their glargine dose is correct. My greatest concern is when people just keep putting the glargine up, and then I see that they go to bed at 16 and then they wake up at 5, and so then it's great because they're now waking up at 5. But what happens if they didn't eat their dinner? What if they didn't go to bed at 16?
Oh, yes.
Then they'll hypo overnight. So the before bed and the fasting, if you're trying to titrate glargine, is the best way to go.
Cool.
All right, let's keep going. So once again, it really comes back to the individual patient and what we're trying to achieve. Balance benefits versus harm, the candidiasis versus heart failure. So if they've got really bad heart failure, I'll see if I can manage their candidiasis. The lady that you're talking about,
I'm sorry, I just have to laugh about that for a moment.
The lady that you're talking about, she's very lovely.
Yes.
And I've feel that we've done enough damage to her poor vaginal area that she needs to just stop it. But you do manage benefits versus harm. Insulin is not a last resort. Put it in earlier. If someone's got an HbA1c above 10, okay, if they've got an HbA1c above 12, they really need to go into insulin early. So
amen to that.
And HbA1c is important, but it's not the only factor. And as Kirli mentioned, the actual monitoring of the blood glucose levels is really, really useful and important. All right. Is that another question that we've got?
Oh, yes, we have too. How exciting. It says, and this is from Danny, how often do you have to, oh God, he's lost it now. Come back. Oh, well done. I'm glad one of us can do technology. Is it the left click? Okay.
Close that.
Oh, we could just need to ask it again.
No.
This side, maybe? Chat. Oh, hang on. How often do you do insulin glargine twice daily versus once a day? Good question. Really good question.
Depends on the individual. Glargine, whilst it's sold as having a 24-hour half-life, it doesn't. And so some patients, it works quite well. Some patients, it does need to be split because you find that it works really well and then it just goes sky high overnight before they wake up, or everything's been going really well and then they're just not making it through to dinner time. Now, if someone's got type 1, I do things like basal testing with them so I know what their glargine is, if it's working for the whole day. But if someone's got type 2, I will often split it if just things aren't right and they are willing to split it. Now, yes, it will be better if you split the doses, but then they've got to take 2 injections. And if you're trying to get them to take their Nova Rapid and getting them onto insulin has been a huge challenge, then I keep it together. But at the same time, once they're needing the higher doses as well, they often do deal with it better split. Caroline, have you got anything to add?
Oh, can I just throw a rule spanner in the works and say it's not PBS listed for people with type 2?
Glargine.
Isn't
I'm
it?
aware of.
Really?
It doesn't actually specific. I think it just says diabetes rather than type.
Does it have a change there?
Yeah, I think they've changed. No, the one you're thinking of is Protophane.
Oh, wow.
I'm not on the internet.
Protophane. Okay, we're going to have to Google again. Protophane, that's one I don't see all that often.
That I love for my pregnant women, but we don't use a lot if they're not pregnant.
Well, we see it listed. We see it all the time.
Protophane.
Glargine.
Yeah.
Split all the time.
Oh yeah, that's
yeah.
I've seen that commonly as well. Yeah, absolutely. And I've often wondered what was the advantage. I mean, I've done it once when I had a patient who was on a very large dose of glargine, and we couldn't dial it all up in one go. And
Well, if that's the case, then you would. I'm sure it wasn't.
Insulin, I don't think has actually even got a restriction on it.
Hasn't it?
Glargine doesn't have a restriction on it. Are you thinking of Levemir?
Oh, no, Levemir's. Oh, maybe for people with type 2.
Yes.
Restriction. Type 1. Yeah.
Right.
Yeah. So Levemir is not on for type 2s, but
Right.
Glargine is.
So. Sorry guys, I'm going to mention the brand name again, Lantus, or now that brings us, yes, exactly. Kimberly, can I just get you to talk about, because I think that's actually a really important point for us to make.
We'll make one last slide and then we'll go through. So the treatment of diabetes, don't forget that you need the diet and exercise. And I also explain to patients that type 2 will progress. It's pancreatic failure, not patient failure.
Yes.
So if they're doing everything that's right, and then they end up on insulin, they can feel really dejected and like they've done something wrong. And I explained that the pancreas burns out over time. And I even explained that to them early on. We will need to keep adding agents. We will need to potentially cut insulin. And they're much better at understanding that it's not their fault.
That's exactly right.
Yeah, it's so important.
Yeah, and I always foreshadow the insulin very early. Yeah. Yes.
So 2 things, I think.
Yeah.
There's been that whole rumor that Lantus has been discontinued.
Yes.
Yes, it has in theory because it's come off patent. So Sanofi have made their own brand, which is called, just talk brand names, Optusulin. So silly the names.
It is a stupid name, isn't it?
It's quite difficult to get your tongue around. Well, so this is where we're going to start seeing in community, because we've never called Lantus Glargine. Really.
No, it's always been Lantus.
It's always been Lantus. So this is where we're going to see the prescribing word Glargine come out. So there's Semglee, which is made or imported into Australia by Mylan, the company. There's also Optusulin, which is up on the screen now, I think.
Yes.
Which is Sanofi's brand of which is just a ploy to try and get us to still dispense and doctors to prescribe. And I thought you had another one.
Yep,
no,
and
I've
then
not
there's
seen
No, I've never heard of that.
I've never heard of that
So,
either.
and this has been a big headache from a pharmacology and an endocrine point of view for me. So there's a thing called biosimilars where they're very similar but not identical, and it's when they're a protein, a biological. So Optislin is not a biosimilar, it's a bioidentical. They have literally continued with the same E. coli, the same bats. They're now printing green stickers instead of purple stickers, and it's Optislin rather than Lantus. It comes in the same pen devices and it comes in the same cartridges, just like Lantus does.
And their cartridges will fit in their Sanofi pens.
So
everything's the same.
Yeah. Okay.
So from the 1st of July, unless a pharmacy happens to have some still in store, they're not going to be able to have it anymore.
Yeah.
The Semglee, as you can see, it looks slightly different. It is a different pen. They do come in pen devices only. They don't have the cartridges. They dial up to 80, just like the Lantus used to, so there's no advantage with this one. But this is a biosimilar. It's not exactly the same. So I'm a very big one for ticking the brand not substituted when I'm talking about my insulins with my patients, because pharmacists are able to say, well, Semglee and Optislin are both glargine. We can interchange the brands. And for a lot of generic tablets, that's great. You can pick a cheaper alternative. But these are not exactly the same. They're very, very similar. And for some patients with unstable diabetes, swapping and changing between brands, we don't have any evidence to suggest that they're not going to need a change of 1 unit or 2 units. And when we're talking kids, and we're talking people with very insulin sensitivity, I don't want them changing between. And also the pens look different. And I tend to run my clinic on, what colour pen do you take?
It's like aspirin inhalers.
What colour's your inhaler? What colour's your insulin? I'm on a grey insulin. Okay, so I know that they're on the grey. If they say that they're on blue, well, is it blue because it's Nova Rapid and it's blue and orange for Nova Rapid, or is it Semglee because it's blue? So Mylan has done a particularly good job at marketing to a lot of the regional pharmacies. So that we're seeing a lot more Semglee from country. But we're seeing a bit of a mix in the city, and I'm personally just changing them straight over to Optislin because it's exactly the same thing, it's just a new sticker.
And can you bring 2 GO? Well, you tell me about this one first.
Basla is TGA approved, it's the first one, but it hasn't been put on PBS, so there's no good reason for you to prescribe it because it's not on PBS, but it is available. Just in case you happen to see it or hear it.
So have they made the application to the PBS, or is it?
No, they never did. They never did it. They
Okay.
TGA approved it in 2014, and then they never did because they thought that Lantus had the market share. And then as the patent ran out for Lantus, they just haven't got around to putting it on for PBS. But I suspect that they may, which is why I just wanted people to have seen it, heard of it. If it turns up one day, someone's put their patient on it, they have heard it before. So which to pick? You have the right to pick whatever you want. Your patient has the right to pick whatever they want. But I pick Optislin because there's still the cartridges that are available, and some patients like to be environmentally conscious and use a pen device, use a long-term pen that they then put the cartridges in. And from an SA Health point of view, we swap everyone over to Optislin because in the hospital we draw up from vials rather than injecting patients individual pens. So everyone will get changed over, and then there will be potential confusion out there. Well, they're now on Optislin of 40 units, but they're also on Semglee of 40 units. Now they're taking 80 units of glargine. There is that risk. We have fantastic pharmacists on the wards that try and help provide patient education on discharge.
Yes, but we also have discharge letters that have a 90% error rate on medications.
Yes.
Because they're written by poor junior doctors. That's okay, we're working on that, guys. But
So the other thing that we spoke about was Toujeo, which is a new insulin to market, which is the first insulin, and there are others that I'm aware of by different companies, that has the first change in strength. This was the first to hit the market.
The first to hit PBS.
Yeah, sorry, the first hit PBS, yes. So this was, my understanding, is not going to be on the SA formula.
No, and I hate it, and I wish no one would ever prescribe it, so please don't prescribe it and send them to me, but I will still see your patients if you want to.
So the issue that we've got is that I've seen, just from a pharmacist and diabetes educator perspective, in the last probably 3 months, 7 prescribing, well not prescribing, but errors coming through, because the person's been on Toujeo, gone into hospital, and because you can't draw back with a needle, if they're not able to self-administer the pen, they've been swapped back onto Optician, or Lantus as it was before the change, then come back out, so kept on Optician, Lantus, etc., Glargine in hospital, then come home and started back on what they know as their long-acting insulin, and thought, oh, I've started on a new insulin as well, and doubled up on their medication.
And I can see how easily that could happen.
Or the long-acting insulins.
Since Lantus was got rid of, so to speak, I've seen a huge rise in Toujeo, because a lot of people didn't realise that it was just getting a new name.
That's
and
right.
so there was a huge panic, well, what am I going to put them on if I can't put them on Lantus? They went on to Toujeo. There's no real good reason to prescribe Toujeo. It's 300 units per mil instead of 100 units per mil. You can still only dial up to 80.
Yeah.
So when people are on very large volumes, and I'm talking like more than 100 units of Glargine a day, then yes, you may consider this, because then there's a smaller volume for absorption. But if you go over 80, you're still going to have to do 2 injections anyway, and I tell them to inject at different sites. Now, the drug companies love to go on about the reduction in hypo risk with Toujeo versus Glargine. Well, it is Glargine, and no, there is no real significant difference in practice. So a lot of people have picked up on that, but there's not, and the risk of overdose when things are pulled out of cartridges and then going into hospital and swapping things over is really great. And the other thing is, they're not bioequivalent. So 1 unit of 100 units per mil Glargine is equivalent to 0.8 units of 300 mils per mil. Yeah, so swapping between the two is quite dangerous. So I avoid it at all costs. And it's also not approved in pregnancy. So the only one we've really got evidence for in pregnancy is the Lantus, which is the Glargine, and given the Optician is exactly the same, I'm continuing on that.
That makes sense to me. Yeah.
Now, complications. We can jump through this very quickly.
Because I think that's something that as GPs we know a lot about.
You're really great at it. Because
I love these charts.
Yeah, so, and I use it for patients to help them work out their risk as well. And so type 2 diabetes is an independent risk factor above and beyond any other of the metabolic issues. Now, don't forget blood pressure and lipid control. So from this study, if you see the blood pressure is in green and the blood sugar is in orange, you're actually having a bigger impact by treating someone's blood pressure properly than treating someone's diabetes. And their LDL cholesterol lowering is also more significant. So patients come in and they say, oh, you know, my blood pressure is normally 140, it's fine. Bringing that down is actually going to be just as important, if not more, than trying to reduce their HbA1c. Multifactorial, we all know about that. The complications, the retinopathy, 10% of people with type 2 have it at diagnosis. So I screen everybody from diagnosis because most people with type 2 have had it for quite some time beforehand. There's proliferative and non-proliferative, and they can get macular edema as well. If it's treated early, it can be effectively treated, but once they go blind, there's nothing you can do about it. So I get patients to do it yearly, particularly if they have it already, but you can do it 2 yearly if they're very well controlled. But as we mentioned in earlier studies, good control really has a reduction in retinopathy, and sight is everything. Someone losing their sight is such a big issue.
It's enormous. It's absolutely enormous. And can I just say one thing about the screening? I know at the Royal Adelaide we've got a huge problem with ophthalmology waiting lists, and optometrists can do
Yes, so I don't send them, I won't send them to opt out, however much you beg and plead, because optometry can screen. It's Medicare rebatable. You just need to tell them that they're going to have drops put in their eyes, that their vision will get blurry, so they can't drive home afterwards.
Brilliant.
But all they need to do is book in with any optometrist. As I said, it's bulk billed. But they need a slightly longer appointment so that they can have the drops put in and everything can be done properly. So it's not necessarily just to turn up and when the optometrist thinks all they're doing is a visual acuity.
So they just need to let the optometrist know in advance. Cool.
Yep.
Excellent.
Neuropathy, we see a lot of, it's the glove and stocking, but they also get autonomic problems, which is worth remembering.
Yes.
The hospital hypotension can be quite significant. The gastroparesis, so then they get nausea, vomiting, and then they can get an enteropathy where they get diarrhea or constipation. I send them for yearly, I do a screen myself every year and then refer them to see podiatry.
That's with those microfilament things that you, and looks like Kirili does that too.
Because by the time they're seeing an educator, their GP, myself, I don't do it more frequently, but I make sure I take every single person's shoes off at least 12 monthly. Having worked in the territory where unfortunately they do have some very bad type 2 diabetes. No, my feet are fine, my feet are fine. I take off their shoe, I see a whopping great big ulcer. Are you aware of that? I've never seen it before, and it's on the sole of their foot. So I always make them take off their shoes.
Because they've got the neuropathy.
Exactly, they're not going to feel it.
No, exactly.
The kidneys do a yearly urine ACR, the albumin creatinine ratio. It doesn't need to be done more frequently than yearly unless you're specifically monitoring it for a reason. If someone does develop an albuminuria, then an ACE inhibitor or an ARB. But not both.
No.
Yes. So the Freedom Trial demonstrated that you very much shouldn't put the two of them together because you actually worsen diabetic neuropathy, nephropathy, the kidney one. Yep. And referral pathways is very important. I'm happy to talk about this, or anyone else. I can keep going to say.
Do you want to talk about it? Let's
So I guess the thing is that what, like we very quickly touched on before, most of the Royal Adelaide is now chock-a-block,
yes, waitlist problems. Oh my God, yes.
Blown out. No longer to see an educator, you have to have HbA1c above 9% and a complication. Flinders is now struggling. So there are under the ADA, Australian Diabetes Educators Association, on the left-hand side of their home screen. I think we've got that.
Last page.
Yes, so dietitians, and there we are.
On the left-hand side,
ADEA.
All you have to do is type in the postcode, and it should bring up credentialed diabetes educators and what their main areas of interest is, whether it's pump therapy, type 1, type 2, gestational. And dietitians is the same, so that's your next slide. So these are all the people that again exist in what we call the private sector. Again, we should probably stop using that word and just
I think we should call it a community sector.
Community, So I just wanted to make everyone aware of that, just so that like we talked about, there's probably small gaps for most of the people now because Medicare have held their rebate, as we all know, for quite some time. And existing in the community is quite difficult because it's all small businesses.
It is.
But like I said, I saw that client last week, and he said he rang GP Marion Plus, and their wait list for diabetes educators has blown out to a year. And as you talked about with the legacy effect, someone who's newly diagnosed is quite a year is quite scary.
It's a long time, isn't it? Yeah.
And when we're talking about these long wait lists, it's for type 2s. If
Yes,
someone's a newly diagnosed type 1,
Yes.
we'll get them in that day.
Yeah.
Like, it's one of those things.
Yeah.
And for the public sector, you really do need bad type 2 diabetes, simply because everybody's got it.
Yes, it's
It's so difficult. I tend to be able to get a type 2 into my Max clinic at Sefton Park within a week, because they're the more complex patients that we do always just extend our clinics for. But if you're going to go to a regular endocrine clinic, there's a very good chance that won't be seen, or you have to wait for a complication. And just going back to the referral bit, so yes, GPs, don't forget, you're at the centre. You're the ones that help coordinate everything.
The little spider in the spider web. That's
it's great. So you can have an endocrinologist. You don't always need one. Diabetes educator, a dietitian, a podiatrist. And then not to forget the psychologist and mental health support. Because some people, they not accepting of their disease state, so they don't do anything about it, or they're so stressed because now they're going to die from diabetes.
Yes.
Or there's lots of things.
Or they've got a history of childhood trauma, which is one of the reasons they're struggling to lose weight. Or there was the lady that you were talking about, she'd had that very negative comment made.
And had bladder.
Yes.
And so then she was diagnosed with type 2, but that actually turned out to be bladder. And so there was this whole thing about, it's my fault, but it's now type 1 or bladder.
Psychology is really important.
Very important.
And unfortunately, none of our public hospitals have a psychologist with our diabetes unit. Sefton Park's Max, we've got a mental health OT, and she helps us with more strategies about how are you going to actually take your medication, how are you going to get up and do your exercise. So it's very much for those patients. You can get in quite quickly to see her, but if it's the underlying anxiety disorders and things like that, who needs a really good psychologist, unfortunately we just don't have it.
And can I just say, I think, only because I'm one, but of course, the pharmacist is really important.
Sorry.
No.
And that's actually really important.
It's really important in the referral pathway. It's not even in the annual cycle of care, but the amount of people that I see, and I can't take my pharmacist's hat off, of course, but I'll say to them, how are you going to take your medications? And say anything. And then I say, so what do you do when you forget to take your medication? You say, do you ever forget to take your medications? They go, no. So I say, what do you do when you forget to take your medications? And then this whole verbal diarrhea comes out, and they go, when I forget to take my insulin, I do this, and when I forget to take my metformin, I do this. And I'm like, okay, now we're getting to the crux of it. And how often would you forget to do that? Maybe once a week. So now we're getting to the crux of why probably your HbA1c is potentially elevated. So, I'm seeing a home medication or someone who's qualified in diabetes, or asthma or whatever, as a pharmacist, can make a huge impact on diabetes or any health condition.
Yes, and I guess that might be a reason to refer for home medication review, mightn't it? If they meet the criteria.
It's quite amazing. Well, I used to be one, but I dropped my qualification because I'm so busy in diabetes. But you would be astounded at some of the things that I found when I used to turn up to people's houses. Astounded.
We even use the pharmacist for the HMRs when we're worried about what's actually going on in the home. Are they really actually looking after themselves? They come looking quite dishevelled, and they say that everything's good, but you're a little bit worried. We've got a great pharmacist that we even just use for a sneaky, where it's so actually their house is a shambles. Everything's all over the place.
There's mold and everything in the fridge.
You don't use it as a judgment. You use it, so that is what I've been fearing. Now, how do I address that?
How do we intervene? Absolutely.
As I said, GPs are really at the centre, and you can manage most, but there's a whole specialty of endocrinology out there, and so we probably can do something for you. So I recommend that everyone with type 1 sees an endocrinologist. I do get patients who like I had one who was 70, she's like, oh, my GP manages my type 1 diabetes.
Wow, brave GP.
I thought that was really great, and then I saw that in fact things were, there's just been some missed things over time. And the reason why we like to hold on to type 1s as well is because sometimes pump therapy is appropriate, and pumps confuse the living daylights out of us. We're not going to expect someone who does it once in a blue moon to be able to run them. And also there's constantly evolving evidence, and this is a group of people that have got this condition for the rest of their life. It's autoimmune, it's genetic. We really need to give them every advancement that's available. And so that's why I think it's important that we see an endocrinologist. Teach them to carb count. The number of people I'm getting referrals for that have never learnt to carb count, I teach them to carb count with an educator and a dietitian. And then the diabetes goes from being all over the place to perfect, because they're now injecting for exactly the amount of food that they're eating rather than just a set dose. So I'm particularly possessive of the type 1s.
You can keep them. You really can keep them. They're scary.
I get asked all the time, what does my endocrinologist do for me? All the time. All the time I get asked. And I'm like, it's insurance.
Yes.
Your endo is your insurance. So if you get sick, if you need a sick day management plan, if you want to change therapy, they sit in the background. And
or if you're flying off internationally, I know we can't with COVID, but you know when they're doing all that weird stuff with
all the travel plans.
Yes.
They're your insurance.
And I think if they needed to ask what their endocrinologist is doing for them, then maybe their endocrinologist isn't actually doing enough for them. They should actually be engaging and explaining. Okay. So then the type 3C, which is the history of pancreatitis, because they're essentially type 1. Now, gestational diabetes, nearly everybody has it these days, and I say if they need more than diet, then they should probably see an endocrinologist. So either if they're in the private world, then have them come along and see an obstetrics physician or an endocrinologist, and we'll work out the appropriate. Whereas if they're in the public, then they'll be seen by us automatically.
You guys swallow them up. Yeah, exactly. The
MODIs, we get involved for diagnosis. We will hold on to some, or we can hand them back with kind of a plan where to go. Type 2s, I like to see type 2s. I know some endocrinologists don't, because they consider it just to be boring basic diabetes, but I'm really passionate about getting on top of it early and getting that good control. It frustrates me when someone is referred after having 10 years of poor control. Just say, we can't get it under control within 12 months. Let's get onto it. Now, some patients need to keep seeing an endocrinologist. Some just need to come back every couple of years when things go out of kilter, and we can make some new adjustments, try different medications. We kind of do this day in, day out. So sometimes, and also being the bad guy as far as the starting the insulin, we're very good at as well. So just because someone's on insulin doesn't mean they have to be seen by an endocrinologist, but we can often get it started, get the education, or we can tweak things, because like I was saying, just taking up the glargine isn't always the answer. And if you don't know, that's fine. Give me a call, give an endo a call, say, is this right? Is this not right? I'm thinking this, not thinking that. I would get at least one phone call a day of someone going, I think I know what I'm doing, but I'm not really sure. And I was going to say, well, I don't know how to treat fibromyalgia. I'd call you for that. I'd call you for how to treat all sorts of things I don't see all day. So just
how to tweak the oral contraceptive pill, for example, because we do it all the time.
I don't know.
And I think that's a really good message to get across. When you're getting stuck, it is actually okay to phone for help. And that's one of the things that we're working on in the hospital, is trying to get good pathways for GPs to get advice when they are getting stuck.
Yeah.
So thank you, Jessica.
No, that's fine. So
yes.
I tend to get more phone calls in a private capacity, but in the public, you can always ring the endocrine registrar. You know, just ring up the local hospital.
And you may not know, and we haven't got the pathway in yet, but we are looking at things around email advice for endocrine, and
Great.
I'll let you guys know when that comes out. Yes.
Podiatry. A local podiatrist is good. The public hospitals will really only see high risk, the active wounds, pressure injuries, infections.
Yep.
There's some details for them, or you can just Google it. But I admit that the SA Health websites are atrocious.
Oh, they're horrible. If you do want advice on high risk foot pathways, then send me an email. It's jackie.yo@sa.gov.au, or you can just email the GP liaison unit and I can put you in touch with the right numbers for that.
Often we get some more rurally based GPs in these talks, and so at Summit Health in Mount Barker, I work up there seeing patients as an endo, but we've got a fantastic dietitian up there, Alex, who's specifically trained in type 1 education as well, so she carb count educates all my patients. And then there's a couple of diabetes educators up there. I just sent all my referrals to Kathy Savage. I know that there's more up there, but they seem to get done that way. And they can also do counselling. That's through considered public health as well. Sarlan, we've got the diabetes educators, Carlin as well. Really, it's going to be more for type 1s and bad type 2s.
But you know, I must say I'd probably go community diabetes educators.
Which then came under which was, please consider community diabetes educators. Now, they are all very different because they've got very different interests as well. Some are very good with type 1 and some are much better with working on that type 2 metabolic patient. Some know how to live and breathe a pump, some don't do it, so then they're not so confident with it. So it's really about finding an educator in your area that can do what you're needing them to do.
And that's listed when you look up the suburb or roundabout and click on the person, it has a listing of all the stuff. And that's kept up to date.
And the other thing we didn't mention when we were talking about psychologists is that we actually have, you can do the same thing with the Australian Psychological Association. There's a psychologist. There you go, I'm educating you guys.
Fantastic.
Mental health is my thing. So yes, you can, and you can look at interest areas and where they geographically are and those sorts of things.
That's great. That's really good because when I work in obstetrics, I'm forever trying to refer to psychologists, but I'm like, please go back and see your GP because I don't know any good psychologists in this area.
And the advantage, of course, of seeing their GP is that they can give you a mental health care plan if that's appropriate. So that can be quite useful too.
And just logging in with their GP, which I find it's harder to get them in to see their GP, like it's in them willing to go sometimes than I would like. But we definitely value you guys.
We value you guys too, both of you.
All right.
Now, did we have any questions from anybody? Because we've kind of been picking up hang on, we've got, are you an endocrinologist in the public or private at Summit Health?
Okay, so for doctors at Summit, they're only private. So I go to Summit for I cover endocrine, obstetrics medicine, and clinical pharmacology, which the clinical pharmacology is basically drug reviews, interactions, and hypertension management. Endocrinology is fairly self-explanatory, and the obstetrics medicine is any pre-existing or condition that develops during pregnancy. I won't deliver the baby. I faint at the smell of Lycor, so we keep me out of the room. But I'm at the end of the door, and the nurses tend to be yelling at me, asking for advice. But anything that's medical, so I'm very used to dealing with women through that.
Do you do
preconception?
Yes.
So in the I do that privately and publicly. Publicly, we've got preconception with obstetrics medicine there, but I think our next appointment might even be in December for preconception, which is really, really hard. We're super understaffed. Our clinics are always overbooked, and so I do recommend. Doesn't necessarily have to be me, it can be any obstetric physician or seeing their individual specialist for preconception advice, because it makes a huge difference for diabetes and any condition to get the disease optimised before falling pregnant. One, for the fetus from having complications, but two, for the mother. If you've got well-controlled chronic disease when you fall pregnant, your pregnancy is much smoother. And so I say to my patients, I'm not involved in conception. I just want to talk to you before and bring me after. Just keep me out of the middle.
I'm so glad you're not involved in conception. That's very good to hear.
So at Summit, unfortunately, we only have private. But
I can certainly, and I mean, I don't want to overwhelm the Max clinic, but it is a great clinic. So I can certainly, if we're, do we send out details, or are we able to put anything? Right, okay, so I can put details of the Max clinic up and how to refer, which, you know, is not a difficult thing to do.
No,
but it's the complex, multi-problem kinds of things that you guys really like, isn't it?
Oh, it is. It's the messy stuff that no one likes to touch. We're not a diagnostic clinic. So a lot of people think complex care, I've got this patient, I haven't been able to work out what's wrong with them for 10 years, I'll send them along.
No.
We're more of they've got all these problems, and we try and optimize those problems, and we see them quite frequently. So I see patients every week, every fortnight, every month, depending on what they need, fix everything, and then see them intermittently and send them back to their GP. It's kind of like a GP helping hand, tidy everything up. In our clinic, there's myself. Most of us are clinical pharmacologists by training, so we do a lot of drug-based optimization, but we've got a cardiologist, a couple of general physicians, a geriatrician, I do endo. I tend not to see any obstetric patients at the RA, but that's because RA doesn't deliver anybody. But if they were young and needing preconception advice, I would do that, but it's not specifically a referral for that, because the RA freaks out when they hear that there's a fetus in the belly and tests them somewhere else.
I do have a patient who managed to deliver a baby at the RA, but it was accidental.
Yeah, it was probably in the car park.
Oh no, it was in ED. She managed to get that far.
Do we have any other questions?
I think that sort of seems to be, there's a silence and nothing else I can see on that. Unless if there's any hidden anywhere else now that we should know about.
If there's no further questions tonight, it looks like it looks like that's it for the evening. And if there's no further questions, that concludes tonight's session. I'd like to say a big thank you to our lovely panel. So that will be Kimberly Chambers,
Jackie Yo,
and Jessica Gaylor as well. It's been a very informative education session, and we hope that everybody found it valuable and relevant to your practice. Just a reminder that you will be prompted to complete a brief evaluation when you leave this webinar. So please do take the time, as your responses will help us improve future education sessions. Samia also have a number of education sessions coming up, so please do sign up to our newsletter called Cognitio, or visit our website to see what's on offer. Thank you to everyone again for your attendance, and we wish you a good night.
Thank you very much. Good night, everyone.
Good night.
Good night, thanks.